Our next speaker is Dr. Oded Bahat. And while I'm introducing him, I want to say that he was nice enough to put together a very nice collection of his references for his lecture. So please go to his website, odedbahat.com, so www.odedbahat.com, and you can just Google it. I did it last night, and go to the link where it says AO, and it has references there. So you can actually have all the references there for his lecture. Dr. Bahat is a private practice in Beverly Hills, California. He focuses on periodontics, surgical implant placement, aesthetic, plastic, and reconstructive procedures. He also performs operations several times a year, not only in California, of course, but in Europe, along with teaching there. Dr. Bahat received his dental degree in South Africa and earned his postgraduate degree in periodontics at the University of Washington in Seattle. After that, he served as the chair and director of postgraduate periodontics at the University of Southern California. He's published over 50 scientific articles and edits in textbooks articles used to educate clinicians surgically and aesthetic reconstructive techniques. He lectures extensively, nationally and internationally. It is my pleasure to welcome Dr. Oded Bahat.
You have the pointer. Thanks, Dr. Butler. Thanks, the Academy, for inviting me. And I will be presenting to you today about facial aesthetic, craniofacial growth, and its influence and impact on implant reconstruction. As Dr. Butler has mentioned, there are 57 papers in the scientific literature, from dentistry to craniofacial to plastic, and the best papers, in my opinion, are coming from forensic literature. In summary, if you want to look at all those papers, the conclusions are very simple. Craniofacial growth continues throughout life. We lose up to 40 or 50% of bone volume. We lose 50 to 60% fat volume. Those variations change between men and women. The onset is not exactly clear. The magnitude is also not so clear. So we published plenty on horizontal reconstruction, vertical reconstruction, what I used to call the J-graft. The problem with all my reconstructions are that time is the most important factor. Ladies and gentlemen, we age. So what are the facial changes? I had Curtis Jensen when he was young, on the screen now. And as you can see, we lose bone volume, we lose the soft tissue volume, we lose elasticity, we lose fat, yet the implants are placed in space in one dimension. What you also see is that the central ligament pull, the lateral ligament gets weaker, and that happens all over our body to support a weakened skeleton. And certain highlights around our face change as well. You can see that around the eye or the cheek or the lips, those highlights are reduced. And that is because loss, again, of bone volume and fat. So the question is, what happens to an implant that you place at age 30? What happens at 50? And we saw some great result in surgical and aesthetic reconstruction. And it's all very nice to show 100 patients 5 years later. And my question is, where is the fourth dimension? How does it look on time? Because everything else changes. Now, our eye functions like a very sophisticated lens. And it picks up light stimuli from certain highlights, which are all elliptical in shape. And when you compare the young and the old, you can see that those elliptical structures or Fabergé eggs are reduced with time. And that's, again, bone, elasticity, skin, etc. Now, those structures are important because they allow us to discern space, distances, aesthetics. What is the difference between a young face and an aged face? And there are also 6 angles that assist us in, in seeing distances and shapes as well. And they are around the eyes, the cheek, the lip, and the jaws. Now, when you compare again those angles, in the young and old, you can see that in old, those angles are reduced dramatically. So, if the face is changing and the bone is changing, what happened to the implants and the teeth? And this is a patient that we reconstructed in 1993. She was an adult patient. The restorations were done by Stéphane Naret and Faridun Daftari. We placed the implant at the two laterals. It looked very well in 1993. And in 2008, not only that we have migration of the alveolus, but we also have extreme thinning on the facial aspect. And this is something that we'll talk later in my lecture quite a bit on surgery reconstruction and implant placement. When you look at some fixed positions, and that is the distance from the apex of 8 and 9 to the implant, you can see the migration of the alveolus over time. So I'm very interested in what happened 2-3 years later, especially with some presenters who present soft tissue reconstruction. It's much easier than bone. But I would tell you that the bone also changes. Let's look at another situation. Lateral and canine placed, again restored by Dr. Daftari. Looked very well when it was done. 10 years later, we have a substantial problem. The remaining alveolus migrates inferiorly, over-thinning of the facial, which always happens in females and sometimes in male, and of course we'll have the open contact with it. Now, does that mean that I place less implants? Absolutely not. But I have to modify my thinking, counting for the fourth dimension of time. Does it happen in the lower jaw? But of course. This is a patient in the 50s, placement of implant at 30 and 31, within 2 years, open contact. This case is an interesting one because I reconstructed the sinus and built the facial bone with a veneer graft. The patient is in the 50s. Will the bone that are placed in the sinus and the facial bone that are reconstructed behave like native bone and native anatomy, or will it behave like a graft? Well, interestingly, the bone that you graft behaves like the site. And that's exactly what happened. 3 implants were placed. 3 years later, the remaining maxilla moves. The implants are anchored in space. They prevent local bone development, and we have a problem. So now all our grafts will behave like the local area. So another situation here, and it's also common for male and female, posterior maxilla right side, reconstructed veneer graft, crestal graft, that is a J graft, and the sinus. And 2 years later, it looks pretty good on a radiograph. But what happens in male and female on all your patients, for some reason or another, the facial bone will be missing. And then many pathological issues will develop because you start showing threads, more on the second molar, slightly less on the first molar, etc., on all facial aspects of implants in the maxilla. So the way I think today on implants, it's very much like a lighthouse. The lighthouse is stable, nothing changes. But then the storm of aging comes in. The lighthouse is stable, but the whole environment, the whole scenery of the face has changed. And usually it happens in winter. That's when we go down. Now the question is, what are the clinical parameters that we have to change? And that applies whatever implant system you use. It's a thinking process. We have to change to account for those changes. And let's look at some variation that happened. Who are the risky patients? In a normal patient, in a normal skull and normal jaws, your variations would be more minimal. In a long face and a short face, from the literature, those changes will be much more dramatic. So you are safer in a normal face. Another variation that happens both in male and female is if you place the implant in the center of the ridge at 35, it will not be the center of the ridge at 45. Doesn't matter how much reconstruction you're going to do, and that is because you will have bone resorption on the lingual, bone deposition on the facial, increase intermolar space, so the central ridge is not anymore the central ridge. And to simulate those changes, let's take the mandible, introduce resorption, so it's not anymore along the red line on the lingual. And we introduce further changes, and that will occur to all your patients. Will it always be clinically significant? No. But we have to plan because we do not know where will it be clinically significant because this resorption will always be there. So we sometimes speak about, well, we get peri-implantitis on the most distal implant because we lose threads. Yeah, we lose threads because of the dynamic changes of the face and the bone. So that is a physiological phenomenon that may cause other changes. And you're going to lose more threads on the most distal implant and a little less on 30 and a little less on 29. But that's a physiological, normal changes of the face. Now, here I've got some Catkins of Curtis's friends. They are 21, 57, and 76 years old. Granted, they are different specimens. But the general features that you can see in the females is that the mandibular angle will increase, and there will be a downgrowth of the premaxilla and lingual vector. In the male, the differences will be different, and that is the ramus will increase in length, there will be auto-rotation on the mandibular angle, but the maxilla will grow just from straight down, not down and lingual. That will have major influence on your implant placement. So, how do men and women differ as far as onset? And that's a clock. Well, in male, it seems that most of our population starts with very rapid aging process around 50. There are many reasons, many hypotheses on that. There's nothing clear as far as why. Females will start early. So my suggestion to you in deciding timing of implants, look at that aging phenomena the same as you would not place an implant at 13 years old, where they're going through puberty. This is a risky gradient. To summarize to you the changes on a female, the mandibular angle will increase, the anterior maxilla will grow down and in. And that's why you'll see on the implants at 7, 8, 9, and 10, not only downgrowth of the alveolus, and you have to compensate for that, but you also see crowding on the lower incisors often, which I always thought is changes of the bite, but often it's result of just straight downgrowth of the maxillary anterior area. If you draw a line from nasation to the inferior border of the mandible, you can see that that angle is increased dramatically. That is, the lower third of the face with aging will change. So the implants that are placed in the lower third of the face will also have repercussion on aesthetic results. Now, in young men, on young male, the changes are different. In this situation, we'll have straight down growth of the ramus. It will elongate. We'll have auto-rotation of the mandible, and the anterior maxilla will just grow down and in. Therefore, the implant in space are different. So, to summarize, the male changes, a 21 years old male, 78 years old male, anterior ramus, the ramus will be elongated, some auto-rotation, and downgrowth of the anterior maxilla. So, we have to develop a risk algorithm. Who are the risky patients and what are you going to change as far as reconstruction? Who are the reduced risks? That makes sense. Those patients with lost myline, those who have minimal aesthetic expectation, symmetrical implant placement, of course, it's less risky. If you're going to place it 7 and 10, they will inhibit bone development evenly. Those that have intact facial bone, Certainly, if bone is going to change, then those with more bone will change less. Those that have a soft tissue biotype that is thick, and those that are coronal adjacent tooth, the tissue will be more coronal. And then, of course, those that are flat architecture or thick periodontium. Now, regarding point number 2 of minimal aesthetic expectation, I just never had a patient that came to me and said, please place implants but make me look less attractive. Doesn't happen. So what we do have to discuss are those with high risk. And those are the patients with high smile line, those who expect aesthetic improvement, those who have a short and long face, those who are on a tangent of a rapid growth and aging, those that the bone is missing, the soft tissue biotype that is thin and scalloped, and all those clinical factors we cannot change. They are given. They have long face, they have a long face. But the clinical decisions, and that's the second part of my lecture, are things that you can change and I've changed. We have to modify the osteotomy. We have to think about asymmetrical placement. Implant diameter is a major decision. Implant macrostructure and microstructure we will be discussing. How do you graft? And it's almost like two camps. Some will graft bone, the others soft tissue, and others will graft alloplast. So 3 camps. And I think there's somewhere in between. Now, what are the aesthetic risks? Let's look first at high smile and low smile. Of course, these are your risks. That's obvious. A scalloped versus a flat periodontium and a thicker biotype, these are your risks. Microstructure and macrostructure. I was fortunate enough to receive 25 magnification of currently commercially available implants. Now, if we know that the anterior maxilla will grow down and in, there will be lingual resorption on the mandibular implants, on the mandibular ridge, you'll have facial resorption on the maxillary ridge. Now, you tell me which of those structures, the macrostructure, will be more favorable for those changes. Okay, then I'll help you. Let's look at 50 magnification. Clearly, bone will resorb more on a rough surface. So in our profession, we try to place a 10 millimeter or 13 millimeter implant, which is a great idea. And we, as in our profession, try to get 100% osteo bone deposition throughout the length of the implant. But then the dynamic changes of the face happened. Well, what will happen on a rough surface like that? The bone will just run. And another issue to discuss, and I don't have an answer, I don't have all the answers, which thread design will be better once physiological bone will change? A round thread? A square thread? I do not know, but that is something that we certainly should evaluate. And that means that for me, clinically, a machine titanium on a collar is my choice. So if you go with a 10 millimeter implant, I accept that I'll have only 9 or 8.5 millimeter of osseous integration. I really don't care because I'm not placing the implant for tomorrow. I want to know what will happen 5, 10 years later. I'd rather live with 85% of integration, and even that doesn't happen, with a smooth surface, so when the changes of bone and soft tissue will occur, I can get away with an aesthetic damage. And let me show you what happens when the apical part of the implant is too sharp, because we're all going for sharp vents and sharp back cuts. So imagine that now you have a patient with a high smile line. The remaining indentation has moved with alveolus, and we have a large vertical discrepancy between the osteotomy and the remaining teeth. And we now, the only solution is remove the implant and reconstruct the site. Well, as you go up the socket, it becomes clear that the implant of choice will be the one that will have the most ease in removing it. because none of us want a large residual defect. What about implant diameter? Well, that's a mistake of mine. At the time the Widebody implants came in, within 3-4 years, the alveolus continue growing, and then surgically, of course, I can solve the problem. But why did I go for the Widebody implant? Knowing, at the time we didn't, or we didn't read the forensic literature, which is available, we didn't realize that it continues throughout life. So for me, Widebody implants in the aesthetic zone are absolutely contraindicated. What about local anatomy, the bone and soft tissue? Well, certainly, if I will ask which one is an implant here, it's hard to tell because I dealt with symmetry. If this is my starting point, I have a problem because I know that with time, we'll have a problem. Now, we're talking about symmetry, and here's 8 and 9 of soft tissue, but symmetry doesn't start and doesn't end just at the coronal aspect. And we look as we progress along the sockets, of course, where you have more soft tissue and when you have more bone, chances are that you will not export threads too early. And the same applies to this interceptor bone. It's not good enough to say, well, I have 2 millimeters of interceptor bone here. This will change with the facial movement. But the issue will be, how does it migrate as you go up the socket? How will be the interceptor bone there? Similarly, when you look at a facial bone, and you say, well, I have intact bone on 8, and I have some disruption on 9, both of them are very thin. And with the downgrowth of the maxilla, and in a female, downgrowth and lingually, you will expose the threads, and you will create an anesthetic environment, as you can see, as we migrate superiorly within sockets. So, what have I changed? What can I control? Well, first thing we certainly can control is our osteotomy, and those of us who are doing it for 10, 15, 20 years, or those of you who are starting it, it's difficult to do because it's difficult to break a new habit. This was my initial osteotomies that I used to do. And I left myself quite a margin on the facial and the lingual to have sufficient bone. But that doesn't solve the problem in a patient that you have, say, a long face or short face, those that have exaggerated resorption on the facial. So you have to change it. Now you have to be much more lingual. Still exiting at the right place. By being more lingual, such as here, and selecting a Widebody implant, what you will do is export threads on the lingual, which will mean that you start now having to graft on the lingual aspect. And that's easier said than done. A typical example is here. We reconstructed the whole anterior maxilla. This is a J graft on the facial, lingual graft on the inside, and this is a corticocancellous graft from the hip. This is from the tori. But if you are going to go lingually in a thin ridge to avoid early exposure, you better be able to graft on a lingual aspect. And, of course, the facial as well. So we have to change the direction of our osteotomy. And if my original osteotomy was this way, leaving myself 2 to 3 millimeters of safety zone, that's not good enough if the maxilla will grow down or it will grow down and in. So that's our original. We have to modify, translate the point of entry to the lingual, such as this. That means the superior point is moved to the facial, and now we start seeing the hystances at the apical part of the implant. So there's another option, of course, and that is translate it to the lingual, move it to the facial, and grab the bone on the lingual. Your third option is to change the diameter. And provided that it can withstand the load, you can go for a narrower diameter and combine those two approaches. So you can modify your osteotomy, you can modify the diameter, but you certainly have to modify the direction to prevent any long-term fourth dimension changes. The same happens in the posterior maxilla. Center of the ridge today, it's not the center of the ridge tomorrow. That means that if I'm going to go central here, and I know that both in male and female I will have facial bone resorption, I will export threads and further threads, because then I will have absolutely no facial bone. So the direction has to be changed. Now, if this is my posterior maxilla, this used to be my placement. I left myself 2 millimeters of bone, and I thought that would be fine. But with time, that doesn't happen. We resorb. So we need to graft. And we'll talk in the last part of the lecture to graft with what. Because I used to be a proponent of autogenous bone only, and I changed that to some degree. And if you compare the two areas, with the grafting and without grafting, of course, pre-resorption, I left myself some margin. Post-resorption, I'm showing threads. So the right approach is, of course, graft and have extra bone to allow yourself for some physiological, normal, dynamic changes of the bone. That means that if this was my original placement and I left myself 2 to 3 millimeters of safety zone, if I'm going to go for a wider body implant, again, we have to translate and move the point of entry and the point of exit of the implant. The same applies to the mandible. This used to be my proper placement. I was in the middle of the ridge, but it's not good enough because we'll resorb. This should be my normal placement, still satisfying the occlusal needs, translate the point of entry from lingual to facial and incline it out. What about my grafting decisions? Always was autogenous bone graft. But we just discussed it, that the graft, once successful, will behave like the local anatomy. So my autogenous graft will behave like the premaxilla. That's not good enough. And of course, to graft, you have to move the flaps over large distances, and I do much more grafting today than 10 or 15 or 20 years ago. And you can advance the flap and graft, or you can use a controlled tissue expansion device. And there are some fantastic devices in Europe that at the moment are not FDA approved here, unfortunately. And when we graft, I also graft the soft tissue so that I can hide the future loss of bone and the aesthetic damage. And this is the case that we grafted initially with connective tissue graft, pre-surgically 2 months before, and then when uncovering, we have the inner part of the flap, which is the one pedicle, and outer side of the flap. Now, what do I graft with? Today, over the autogenous bone, I will graft with non-resorbable material, because the graft will behave like maxilla or mandible. So over that, we'll put whatever non-resorbable material that you wish. You can go with a connective tissue graft. You can go with a dermal graft. All is fine, because you're going to thicken the tissue. And if there will be resorption in that area, in the aesthetic area, at least it will be fibrotic tissue. It will not be titanium threads. So the trick here is thicken it and stabilize it. And that's exactly what we did. In a similar situation of a J graft in anterior maxilla, I always went with corticocancellous graft. We'll graft it on a facial as a J graft. We'll graft it on a lingual. But then we will add non-resorbable material for the one purpose only, and that is make sure that I will have fibrous tissue if there will be any resorption. And then, of course, close always primarily. So for me, the challenge of treatment is not to give the patient next year or 3 years later optimal aesthetic result. I do have to account to the individual variation, and I have to account for what will happen with normal changes of the face. So these are the changes and these are the observations. Craniofacial changes will occur throughout life. It's not going to change. Implant will stay in space. They will not move. They will impede bone movement, so account for those changes. Onset varies between genders. The consent is important that we understand as clinicians, and the patient should also understand what are the changes, what are expected from them. The risks vary between patients, and the risk also, I would add, varies among clinicians. Not everybody has the same clinical skills. The pre-surgical analysis for me, for those patients, have to account for those changes. Your placement cannot be the same. Your selection of implant in diameter cannot be the same. The microstructure, you have to think of an implant that sometimes, in a high smile line, you have to reverse it. A longer crown is not acceptable. Asymmetrical placement is more risky. If you only place a central incisor, you're in more risk than if you place two centrals, because the one will undergo those changes. And as such recovery, especially when vertical growth had occurred, is technically very difficult because you're working in between teeth. Thank you very much.